Welcome to this lecture on organ donation after cardiac death in the emergency department, part of Module 2 in the MSc Emergency and Resuscitation Medicine. My name is Dr. Matt Reed. I am a consultant and NHS Research Scotland career research clinician in emergency medicine based at the Royal Infirmary of Edinburgh. My special interests include syncope and arrhythmias, cardiac arrest and organ donation. I have previously been our ED's donation lead and also led the establishment of an uncontrolled DCD2 program in our hospital. The outline for my talk is as follows. Firstly, I would like to talk about the current practice of organ donation from the viewpoint of the emergency department. Next, I will go on to talk about current practice in non-traumatic cardiac arrest management and how this may indirectly lead to increased potential for uncontrolled organ donation. I will then talk about the challenges of uncontrolled organ donation from the emergency department, with specific focus on the diagnosis of death and how it is relevant to uncontrolled organ donation. After discussing the changes that are required to normal ED practice, I will finish with the Edinburgh Uncontrolled Organ Donation Programme. There are two types of donation that are relevant to the ED: tissue donation and organ donation. Tissue donation refers to the donation of tissues such as corneas, skin, bone, tendons, cartilage and heart valves that can be retrieved from patients who have died from cardiac arrest in the ED. Tissue can be retrieved many hours after death. Tissue donation programs are widespread in many EDs throughout the UK and should be part of any ED's bereavement checklist. Organ donation refers to the retrieval of organs such as kidney, liver, lung and heart. Currently, most deceased donor organs are donated from patients who are confirmed dead by brainstem tests, usually after suffering severe head trauma, brain hemorrhage or stroke. If relatives agree to organ donation, the patient remains on a ventilator until after the organs have been removed. This is termed donation after brainstem death, or DBD, formerly heart-beating donation. Most ED's involvement in these patients is to think of the possibility of organ donation after brainstem death in a patient who has an unsurvivable medical or surgical brain injury, and to arrange intensive care unit admission for ongoing treatment and consideration of organ donation should the patient develop brainstem death. This flowchart shows the process of DBD donation in my ED. An increasing number of organs are now retrieved from non-heart beating donors who are declared dead only after cardiac arrest. This is now termed donation after circulatory death, or DCD. The patient's heart stops beating before organ removal takes place. These patients are usually in the intensive care unit. Their death has usually been expected for a period of time, allowing time for discussion with relatives and planning to take place. Hence this type of DCD, DCD category 3, has been termed controlled. These patients may have passed through the ED during their inpatient stay, but will have been referred to the intensive care unit for treatment, where they may have deteriorated and become potential organ donors after this treatment was withdrawn. Uncontrolled DCD follows donation from patients who are either dead on arrival in the ED, category 1 DCD, patients who are unable to be resuscitated in the ED, category 2 DCD, patients awaiting DBD who have cardiac arrest, category 4 DCD, and patients who die after an unexpected cardiac arrest in the ICU, category 5 DCD. Categories 1 and 2 are relevant to the ED. In the Royal Infirmary of Edinburgh, as in most transplant centres, organs are donated primarily from DBD donors and category 3 DCD donors. There has been a tenfold increase in the latter in the UK over the past 10 years. and controlled DCD now accounts for 35% of deceased donors. There is much less literature on the use of Category 1 and 2 DCD donors compared to controlled DCD donors. On average, 3 of the 10,000 plus people awaiting transplants in the UK die each day, and there is a mismatch between the number of organ donors and the number of people needing a transplant. In view of the current shortage of organ donors, some EDs have begun to investigate the potential for using uncontrolled DCD donors, with initial successful results having been reported in countries such as Spain and France, which both have a well-developed Category 2 DCD organ donation program. Current practice in non-traumatic cardiac arrest management has improved over the last decade, with many centres reporting improved outcomes through better public awareness of the need to perform CPR, improvement in ambulance service call handling and tasking, and the use of advanced cardiac arrest technology such as automated chest compression devices. Despite 2 large trials failing to show that these improve survival, they undoubtedly enable better quality resuscitation to be performed in the back of an ambulance in patients who are being transported to the ED. The standard use of automated chest compression devices in our region undoubtedly means that patients who are unsuccessfully resuscitated from out-of-hospital cardiac arrest are likely to have had better quality resuscitation during transfer to our ED, and are likely therefore to have less organ ischemic injury should they fail to be resuscitated and have previously stated a desire to donate their organs in the event of their death. Another area of cardiac arrest management that has changed in the last decade is the use of focused echocardiography, especially in life support. Previously, of the 4 H's and 4 T's, only hypoxia, hypothermia, and hypokalemia were detectable at the bedside. Focused echo in life support now allows bedside detection of these, along with hypovolemia, thromboembolism, tension, and cardiac tamponade. Focused echo in life support is able to help determine the likely cause of cardiac arrest in some circumstances. In this patient, focused echo in life support was able to make the diagnosis of cardiac tamponade. It can help with the recognition of fine ventricular fibrillation that might show up on an ECG monitor as asystole. It can also help differentiate true PEA from pseudo PEA. True PEA is now the term clinicians use to refer to patients with some electrical cardiac activity but no pulse and no cardiac output on echo in life support. This is differentiated from pseudo PEA, who are those patients with some electrical cardiac activity and no pulse, but with cardiac output on echo in life support. In a study of 204 out-of-hospital cardiac arrests, focused echo in life support showed cardiac activity in 35% of patients with asystole on ECG. Finally, echo in life support can also help with decision to withdraw treatment, and it is this final indication that can provide further assurance to the ED clinician in uncontrolled DCD. A 2001 study showed that in 139 patients with true cardiac standstill, there were no survivors to hospital discharge in the standstill group. The REASON study, a large Canadian study looking at the predictive value of cardiac standstill on focused echo in life support, will report soon, but there were no reported survivors to hospital discharge who have been in cardiac standstill in the ED after suffering a medical cardiac arrest. I would like to talk now about the potential for uncontrolled organ donation, firstly covering the requirements that any ED and hospital require prior to considering an uncontrolled DCD2 program. First of all, there needs to be in place a good relationship with a local pre-hospital ambulance service and an established pre-alert system for cardiac arrest patients. In uncontrolled DCD, the transplant team is not prepared and the organs may suffer a period of warm ischemia. It is therefore essential to cool the organs of DCD donors as soon as possible after circulatory death to slow metabolism, minimize organ decay, and maintain organ viability. Any ED-based DCD program requires close collaboration between the ambulance service and the ED, and between the ED and transplant teams. The ED needs to see a large number of cardiac arrests a year and be part of a system where most cardiac arrest patients in whom resuscitation is attempted are brought to the ED rather than being part of a system where resuscitation is commonly terminated at the scene. It is useful if there is some previous experience of ED tissue donation so that the nursing and medical staff have experience of discussing donation and there is a culture of donation within the department. This also includes having support of senior medical and nursing staff. There needs to be an organ transplantation service at the hospital and also one, preferably two, specialist nurses in organ donation, also called SNODs, based in the hospital rather than being on call from a remote location. In RED, when we first started looking at the potential for uncontrolled DCD2, we discovered that there were about 400 cardiac arrests in our region per year. Of those, half were transported to the ED, 3/4 died in the ED, and 1/4 were transferred to intensive care. Around 40% of those then survived to hospital discharge. When accounting for other inclusion criteria for uncontrolled DCD such as age, early arrival of the ambulance service after onset of a witnessed cardiac arrest, no disqualifying medical illness, the patient being on the organ donation register, i.e. previously having expressed a wish to donate their organs in the event of their death, having relatives available in the ED, and the patient presenting during times when the transplant team and organ donation nurses were available, we found that there were only likely to be around 5 eligible patients a year. Even if these potential patients did not lead to successful donation, this potential probably would still exceed our ED DCD3 program, which referred 2 to 3 patients a year. The other area of potential that we explored was the viewpoint of the public, and to gauge this we performed a survey of ED attendees. 72% of relatives of ED attenders were willing to discuss organ donation should their relative have suffered a sudden death in the ED, and almost 70% of relatives found the organ preservation techniques necessary for DCD2 uncontrolled organ donation acceptable. This work was also followed by a large publicity campaign to inform the public just prior to launching the program. There are many challenges that need to be overcome in setting up an uncontrolled DCD program. Firstly, although there must be no contact between the teams looking after the cardiac arrest patient and the organ retrieval team, there is obviously only a short window from when CPR is stopped until organ preservation procedures must be started. The organ retrieval team therefore need to be activated and in place prior to stopping CPR. The processes and specialist interventions that are required for uncontrolled DCD2 require a large amount of training. Equally, the conversations that are required with family members are potentially challenging and require training and practice. Not only are you breaking the ultimate in bad news, but you are also then asking relatives for their agreement for organ donation, although this is legally not required. The ED environment is a chaotic one with much going on at any one time. These pressures and conflicting demands also need to be overcome. Finally, because the cause of a potential uncontrolled DCD2 donor's cardiac arrest is not obvious, the Procurator Fiscal, or coroner in England, needs to agree that organ retrieval can go ahead. In Scotland, this is a little more straightforward, as deaths within 24 hours of hospital admission are not legally required to be reported. The same is not true in England, where all such deaths need to be investigated. However, even if a cause of death is not clear, with prior knowledge of the DCD2 program, the Procurator Fiscal is commonly supportive of donation as long as it does not interfere with the legal process. The final challenge to discuss in an uncontrolled DCD program is the diagnosis of death. You may think, why am I discussing diagnosing death? It's obvious when someone's dead, isn't it? But there are a couple of pieces of evidence that suggest we are not as good at it as we think we are. Clearly, For the purposes of an uncontrolled DCD program, we need to be 100% specific, i.e. if we diagnose death, we are always correct at diagnosing death. Something that is easily possible as long as we follow guidance. The first evidence that we are not quite as good as we think at the process of diagnosing death comes from a high-profile case from our own ED. This was an unfortunate case of a patient who suffered out-of-hospital cardiac arrest, and despite the ED team achieving return of spontaneous circulation, after prolonged treatment it was decided that further aggressive treatment would not be in her interest. However, the patient didn't succumb to her condition, although she did not make as good a recovery as the newspaper article here suggests. Whilst this unfortunate case may cause real anxiety to those involved in uncontrolled organ donation, there is a fundamental issue here. And that is the difference between a diagnosis of futility and a diagnosis of death, and most importantly, how this was communicated to the unfortunate patient's family. The patient in this case was never confirmed dead. It was merely decided that she was unlikely to survive and that further aggressive treatment should not be continued. However, the message conveyed to the family was obviously that she had died, rather than she was in all probability likely to die. If we follow guidance, we are able to diagnose death with 100% specificity. We cannot and will never be able to be 100% specific at predicting death in patients in whom we think are likely to die, i.e. in whom we think further treatment is futile. A second piece of evidence, also from our ED, that we are not quite as good as we think we are at the process of diagnosing death, comes from a patient who suffered cardiac arrest in the ED after presenting with a stroke. The notes recalled that at 19:30 there was no ROSC after 30 minutes of resuscitation, and the echo in life support scan showed very minimal LV function. The notes go on to state that the resuscitative effort was terminated at 19:30 and that death was confirmed at 19:30. The problem here is that death is said to have been confirmed only seconds after cardiac activity, although minimal, was noted on echo. Surely cardiac activity cannot be present if a diagnosis of death is to be made. This is again a misunderstanding about diagnosing death. What should have happened is a formal confirmation of death should have been performed not at the termination of the resuscitation, but sometimes later, once cardiac activity had ceased. Another definition to clarify here is obviously confirmation of death, which is the process of diagnosing death, versus certification of death, which is merely the process of filling in the paperwork, i.e. the death certificate. So how do we confirm death? Most doctors, if asked, say that you are dead when you've got no heart sounds, no breath sounds, and fixed dilated pupils. Neurosurgeons tend to say you're dead when your brain is dead. Orthopedic surgeons say you're dead when you're cold, blue and stiff. And the public thinks you are dead when your heart has stopped, perhaps not unreasonably. So who is right? Well, what does the law say? Unlike in the USA, there is no legal definition of death in the UK. Courts in the UK accept a determination of death using neurological criteria, and basically you are dead when a doctor says you are. So if everyone has different ideas about how to diagnose death and practice is so variable, what should we do? Well, in 2008, the Academy of Royal Colleges produced this document that cleared things up and introduced a code of practice around the diagnosis of death, defining death as the irreversible loss of those essential characteristics which are necessary to the existence of a living person, which they go on to define as the irreversible loss of the capacity for consciousness combined with the irreversible loss of the capacity to breathe. The UK definition of death therefore requires irreversible cessation of brainstem function, irreversible unconsciousness, and irreversible apnea. Here the UK differs to the rest of the world, all of who define death by irreversible cessation of the function of the whole brain. But we don't use brainstem criteria to diagnose death on everyone, do we? Of course not. Instead, we use cardiorespiratory criteria, as diagnosing death needs to be applicable to primary care and out-of-hospital situations, and not only on intensive care units. We know that if there is simultaneous and irreversible onset of apnea and unconsciousness in the absence of a circulation, then irreversible cessation of brainstem function will follow fairly rapidly. So we're effectively using cardiorespiratory criteria as a surrogate for brainstem death criteria. We will only make the assumption that brainstem death will follow cardiorespiratory death under the following circumstances. Firstly, a decision must have been made either to stop CPR, that the patient is not for resuscitation, or that active treatment should be stopped and is not in the patient's best interests. Next, we need to observe apnea, asystole and unresponsiveness for 5 minutes, as well as confirming that there are no pupillary responses, no corneal reflexes, and no responses to pain. Finally, we must not do anything that may start the heart and restart cerebral circulation, such as place the patient on automated CPR after confirming death, as otherwise brain death may not follow cardiorespiratory death. This is clearly important when deciding on how to continue to perfuse organs in uncontrolled organ donation once death has been confirmed. This 5-minute period observed in the UK differs between countries, as can be seen here, but probably if you have no cardiac output for between 2 and 5 minutes, you will develop brain death. The exact period of time required is not yet universally agreed. So what about this thing called the Lazarus phenomenon or syndrome, I hear you ask, when auto-resuscitation or the spontaneous return of circulation is reported to occur after failed cardiopulmonary resuscitation? Well, this is likely to be a result of not having a standardized way of confirming death, a lack of understanding of confirming death, or having factors present which make determining death difficult, i.e. drugs. Indeed, the case I presented earlier from RED has made it into Wikipedia as a reported case of the Lazarus phenomenon, when clearly it was no such thing. So finally, I would like to come on to the changes that are required to ED practice if we are considering uncontrolled Category 2 organ donation in a patient who has stated their wish to in the event of their death. One of the key principles that should run through the entire process is to ensure that the team looking after the patient and managing the resuscitation have no involvement with the SNOD and transplant teams. A patient's clinical treatment comes above any consideration of organ donation, and it is only once it is decided that resuscitation should be stopped that organ donation should be considered. However, obviously, for practical reasons, there needs to be consideration of the possibility of organ donation prior to resuscitation stopping, as once it has, and once death has been confirmed, measures must be immediately taken to preserve the organs prior to transplantation. For this reason, therefore, the SNOD or specialist donation nurse and transplant teams need to be aware of any potential Category 2 organ donor in the ED as soon as possible. Background checks need to be done to ensure the patient fulfills eligibility criteria, and the transplant team needs to be ready to commence organ preservation procedures once death is confirmed. In our program, the SNOD or organ donation nurse is made aware of all cardiac arrest patients who come into RED. If they fit criteria for organ donation and a decision to cease resuscitation is made, then the clinical team continue resuscitation for the purposes of donation while the transplant team prepare. Once the transplant team is in place, we follow a rigorous diagnosis of death protocol consisting of ECG asystole, cardiac standstill on echo, and no arterial pulsation on arterial line placing if placed for 5 minutes. Only once death is confirmed do transplant team insert cannula into the patient's groins and commence NRP or normothermic regional perfusion. This type of abdominal ECMO, which perfuses the abdominal organs but prevents perfusion above the diaphragm due to an obstructing balloon in the aorta. Once the patient is stable on NRP, an agreement has been obtained from the Procurator Fiscal, the Scottish equivalent of the coroner, then the patient is taken to theatre for organ retrieval. This short video, which now follows, will discuss the Edinburgh Uncontrolled DCD2 programme in more detail. This video is about the Royal Infirmary of Edinburgh Emergency Department's Uncontrolled Organ Donation programme. There are different categories of organ donation. Previously, organ donation from the Emergency Department has involved referring patients diagnosed with brainstem death to the Hospital Intensive Care Unit for what is known as donation after brain death, or DBD. More recently, EDs have been involved in donation after circulatory death, also termed DCD. Most DCD occurs as a result of controlled DCD, or Category 2 DCD, which occurs when a patient's heart stops after a period of severe illness, normally in a setting of an intensive care unit. EDs have been involved in identifying such patients and referring them to the hospital intensive care unit for the purposes of donation. More recently, focus has turned to uncontrolled DCD, which occurs after sudden cardiac arrest. Whilst the Royal Infirmary of Edinburgh's Emergency Department has an active DBD and controlled DCD programme, it is the uncontrolled DCD programme which this short video focuses on. Patients having an out-of-hospital cardiac arrest are treated on the scene by the attending paramedics. Treatment commonly includes intubation and ventilation via a bag valve mask, intravenous access and administration of drugs, cardiac defibrillation if the patient is in a shockable rhythm, and the commencement of cardiopulmonary resuscitation, or CPR. In Edinburgh, a mechanical CPR device, in this case the Autopulse, is used to allow more effective CPR during transit from the scene to the emergency department. On arrival in the emergency department, a handover takes place between the attending paramedics and the receiving emergency medical and nursing team. In the training scenario in this video, the patient is a 55-year-old male who has collapsed in cardiac arrest at his breakfast table. He received CPR from his wife and the paramedics arrived in 6 minutes. The patient's initial rhythm was ventricular fibrillation and he received 4 shocks before the rhythm became PEA, pulsus electrical activity, and now on arrival in the emergency department he is in asystolic cardiac arrest. His downtime is now 60 minutes after his cardiac arrest. At this point in the resuscitation, without any ROSC, or return of spontaneous circulation, the likelihood of him surviving is very low. However, it is extremely important that all efforts are made in the emergency department to identify any underlying causes that are reversible and to consider further advanced resuscitation measures, which may include intubation, if it has not yet been performed, focused echocardiography, as is being performed here, and is showing no cardiac movement, or cardiac standstill, and more anecdotal measures such as transfer to the cardiac lab for emergency coronary angiography, to cardiothoracic theatres for bypass, or to renal for emergency hemofiltration, if any of these measures are deemed relevant and appropriate by the treating physician. Unfortunately, however, in the majority of patients, as is the situation of our training scenario, it is not possible to restore the patient's circulation, and after all possible avenues are explored, the treating physician will make a decision, along with the team of emergency medicine doctors and nurses, that further resuscitation efforts are futile. It is at this point, in uncontrolled DCD centres, that organ donation should be considered. In this patient, the treating team have decided that further resuscitation is futile, however have continued resuscitation in order that the patient's wishes for organ donation may be considered. In Edinburgh, only patients who are on the organ donation register are considered for uncontrolled organ donation. Because the processes involved in uncontrolled DCD organ donation are so concertinaed in time, it is important that in any patient who is given prior authorization and who has the potential to donate his or her organs, the retrieval team is prepared. For this reason, the SNODs, or specialist nurses in organ donation, are made aware of all out-of-hospital cardiac arrests that come into the emergency department in Edinburgh. The SNOD's interaction with the treating clinical team is limited until the team treating the patient decide that further resuscitation would not be in the best interest of the patient and is futile. The surgical retrieval team will on no account have any interaction with the treating ED clinical team at this point. The SNODs will collect background, past medical history, drug history, circumstances regarding the cardiac arrest, and whether the patient is on the organ donation registry, which is mandatory. This process involves collecting a large amount of information very quickly, and for this reason we have 2 specialist nurses in organ donation performing this role. For the purposes of uncontrolled organ donation, as in other types of organ donation, the decision that further resuscitation is futile must be made by both an emergency department consultant and a second senior doctor who has had at least 5 years post-registration experience. The emergency department consultant should go to speak with the patient's family and should take along the specialist nurse in organ donation and also an ED nurse. The emergency department consultant should communicate with the patient's family that resuscitation attempts have been unsuccessful and will shortly be discontinued. One suggested approach is to convey to the family members that when their relative collapsed, their heart stopped, and despite the efforts of both the paramedics and emergency department staff, it was not possible to restart their relative's heart. It is important to emphasise that when the machine that is compressing their chest and breathing for them is stopped, then the patient will die. During this conversation, the emergency department consultant should introduce the specialist nurse in organ donation as a specialist nurse involved in end-of-life decision-making, and further discussion regarding end-of-life choices is then led by the specialist nurse in organ donation. The SNOD explains to the family that their relative was on the organ donation register, which allows steps to be taken to maintain the option of organ donation. If the family agree, this is not an authorisation that organ donation will definitely proceed, only that the family have no objections to organ preservation procedures occurring in the emergency department once death is confirmed. If there are no family objections or further questions for the SNOD, they leave the family and tell the theatre team that they can progress with the organ preservation procedure. If the patient's family are distressed at the possibility of organ donation, then the process is terminated and the surgical team is stood down. The operating team, including ODPs and surgeons, are contacted by the SNOD via a dedicated pager system and make their way to the emergency department normothermic regional perfusion or NRP room. This is an area in the emergency department which is suitable for the NRP procedure and also allows ongoing use of resuscitation rooms by the emergency department should further patients present requiring resuscitation. There should be no contact between any members of the surgical team and the emergency department team caring for the patient until death is pronounced by the emergency team. When the organ retrieval team is ready and set up, the ED consultant will discontinue the resuscitation effort, turn off the ventilator, or cease manual ventilation, and cease manual or mechanical cardiac compressions. The ED consultant will then diagnose death as per the Academy of Medical Royal College's guidelines on diagnosing death according to cardiac criteria, being 5 minutes of no cardiopulmonary activity, further stringently defined here as both asystole on the patient's ECG and no cardiac movement on focused echocardiography as performed by the ED physician. Plus, when available, no pressure wave visible on arterial transducer, and also no respiratory effort after disconnection.
I still have asystole on the monitor.
I can't feel a pulse.
So Matt, do you want to look at the echo and I'll begin to listen for breath sounds for 5 minutes.
If any electrical activity is noted on the ECG monitor, or any coordinated cardiac movement noted on focused echo during the 5-minute period, then the 5-minute period will begin again. This will not affect the ED physician's decision of futility and would not lead to a change in the patient's management except in the extremely unlikely event of significant and sustained cardiopulmonary activity being detected. In this case, the ED physician should reassess the patient. No breath sounds for 5 minutes. After 5 minutes, the ED consultant will confirm death. Okay, that's 5 minutes. Any
So
breath sounds?
there have been no breath sounds or heart sounds.
There's no movement on the echo. There hasn't been 5 minutes, and there's asystole on the trace. So that's a PLE time of 10:24.
PLE then at 10:24. Can we just take the patient off the autopulse and do you want to check the back while
Thank you very much, Morgan.
The patient is moved quickly to the area identified for the normothermic regional perfusion procedure. No more than 120 minutes should lapse from cardiac arrest to cannulation of the patient. The first priority is to prevent reperfusion of the brain after life is pronounced extinct. A cannula with a balloon is placed into the thoracic aorta via the left femoral artery, which prevents any perfusion above the abdomen, and in the right groin, arterial and venous cannulae are placed into the femoral artery and femoral vein in order for the NRP, a form of bypass, to perfuse the abdominal cavity.
Two line, please. One there, another one there. Traffic, please. One more. One more. Leg, please. Right angle, thanks. Guys, ticks. Okay, thank you.
In Edinburgh, a trained member of the theatre team confirms the absence of blood flow to the brain by monitoring the carotid vessels by ultrasound and also by monitoring the radial artery pressure if present. If any flow is detected after commencing the NRP, the position and the inflation of the balloon will be rechecked and the absence or presence of flow will be retested. The balloon position and inflation can also be checked using portable X-ray in the emergency department.
Right. Got some flush. Okay. Irene, where are we at in terms of minutes from PLE? Right.
3 minutes 30 since we came in.
Okay, it's going to be X-rays. Everyone led on, thanks.
To see where I am, position.
Yeah. That's fine.
There is no reason why the relatives cannot see the patient while mechanical resuscitation is ongoing or after the NRP machine is started. Also, whilst the NRP procedure is taking place, the emergency department team will be informing the patient's GP and also obtaining authorisation from the duty procurator fiscal, who is the equivalent of the coroner in England and Wales. After these discussions, the emergency department consultant should be in a position to issue a death certificate if agreed by the procurator fiscal that there are no suspicious circumstances to the death. During the NRP process, the specialist nurse in organ donation will be having a much longer discussion with the patient's family about what the organ donation procedure entails, and will also obtain further details about the patient, which will help decide whether or not organ donation finally goes ahead. Once the patient is firmly established on the NRP, the patient is transferred to the operating room for organ retrieval. The Edinburgh Uncontrolled Organ Donation Programme commenced in January 2015. It has led to the successful retrieval of kidneys for transplantation. We are currently in the process of training on a new NRP machine on DCD3 donors, and the program is also going to soon be integrated into our newly established ECMO program, which we are using in selected cardiac arrest patients. In summary, we have discussed the current practice of donation in the emergency department and of cardiac arrest management. We have discussed the potential, the challenges and the changes required to ED practice for uncontrolled DCD. We have discussed diagnosing death, and we have discussed the Edinburgh Uncontrolled Organ Donation Programme. Thank you for listening.